Hi everyone, welcome back. In today's episode, we cover the topic of spontaneous abortion. Let's begin with the clinical snapshot. A 35-year-old G3P2 at 12 weeks of gestation presents to the emergency department with 6 hours of vaginal bleeding and cramping pain. She has had 2 prior vaginal deliveries and no history of pregnancy-related complications. She has been receiving regular prenatal care. A transvaginal ultrasound was performed and showed a fetus without cardiac activity in the lower uterine segment. This is a case of inevitable abortion. Let's continue with an introduction to spontaneous abortion. As a general overview, remember that it is a non-elective termination of pregnancy at less than 20 weeks gestation. And with regards to epidemiology, remember that it occurs spontaneously in about 15% of all pregnancies. Demographically, it is more common in women of advanced maternal age, that is, women greater than 35 years old. There is about an 11% risk in women that are less than 35 years old, a 17% risk in women between 35 and 39 years old, a 33% risk in women who are between 40 and 44 years old, and about a 57% risk in women who are greater than 45 years old. Risk factors for spontaneous abortion include advanced maternal age. Again, this is defined as being greater than 35 years old, and this is the #1 risk factor due to strong association with fetal chromosomal abnormalities. Other risk factors include advanced paternal age, prior pregnancy loss. The risk increases as number of prior miscarriages increases. Maternal diabetes, whether it is type 1 or type 2 diabetes. Remember that gestational diabetes begins after 20 weeks of gestation, so it cannot contribute to spontaneous abortion. Other risk factors include obesity, thyroid disease, whether it is hypo or hyperthyroidism, stress, whether it is acute or chronic, inherited thrombophilias, conception less than 3 months after a live birth, pregnancy with an IUD in place, and subchorionic hematoma. In terms of the etiology, fetal chromosomal abnormalities present in up to 70% of spontaneous abortions. Other causes include infection, such as from Listeria, parvovirus B19. Remember that there is a 5.6 times higher risk of pregnancy loss if the infection occurs in the first trimester. Syphilis and cytomegalovirus. Other causes include incompetent cervix and uterine abnormalities, such as leiomyomas, polyps, adhesions, and septae. Now let's discuss the classification of spontaneous abortions by reviewing the clinical features of the different types. For a threatened abortion, there will be vaginal bleeding, no passage of contents, a closed cervical os, and on ultrasound, the fetus will be present and it will have cardiac activity. For an inevitable type, there will be vaginal bleeding, no passage of contents, an open cervical os, and on ultrasound, the fetus will be present, but it will not have cardiac activity. For an incomplete type, there will be vaginal bleeding, and there will be passage of contents, with an open cervical os, and on ultrasound, there will be retained fetal parts. For a complete abortion, there will be vaginal bleeding, there will be passage of contents, a closed cervical os, and on ultrasound, there will be no fetus present. Moving on to the presentation. Symptoms include vaginal bleeding, which commonly occurs in the first trimester without subsequent loss of pregnancy. Other symptoms will include abdominal and pelvic cramping pain. Some patients will be asymptomatic, and some may note reduction in their previous pregnancy symptoms, such as decreased nausea or decreased breast tenderness. On exam, the vitals may exhibit signs of shock if there is significant hemorrhage. On speculum exam, one may assess the source and quantity of bleeding. And if the bleeding is from the cervix and there is an open cervical os, then this suggests a spontaneous abortion. If there is significant hemorrhage, then this should prompt an urgent evaluation and intervention. On bimanual exam, one will be able to determine whether the cervix is open, and one will be able to assess the presence of tissue within the cervical canal. This also allows one to estimate the gestational age. And on handheld Doppler, one will be able to listen for fetal heart tones. The absence of fetal heart tones in pregnancy greater than 12 weeks suggests a potential early pregnancy loss. In terms of other imaging, a transvaginal ultrasound is indicated as the key for diagnosis of spontaneous abortion. It helps to assess the fetal cardiac activity. Specific findings include looking for the presence of intrauterine gestation and evidence of viability. A diagnosis of spontaneous abortion can be made if any one of the following is present. If there is a gestational sac greater than 25 millimeters without a yolk sac or embryo. If there is an embryo with a crown rump length greater than 7 millimeters that does not have cardiac activity. Following a pelvic ultrasound that demonstrated a gestational sac without a yolk sac, if there is still absence of an embryo with a heartbeat 2 or more weeks later. Following a pelvic ultrasound that demonstrated a gestational sac with a yolk sac, if there is absence of an embryo with a heartbeat 11 or more days later. And one may begin with a transabdominal ultrasound, but should proceed to transvaginal ultrasound if they are unable to demonstrate cardiac activity in an intrauterine pregnancy. And another imaging modality is a hysterosalpingogram. This is indicated to elucidate potential causes of spontaneous abortion, and it should only be performed after treatment for confirmed spontaneous abortion. The specific findings may include uterine structural abnormalities. With regards to treatment, expectant management includes counseling and return precautions. This is indicated if the patient is at less than 14 weeks of gestation, there is a threatened or inevitable abortion, the vital signs are stable, there is no evidence of infection, there is a desire to avoid surgery or medication, and there is a desire to pass the uterine contents at home. Remember that the majority of expulsions occur in the first 2 weeks after diagnosis. However, if the expulsion is unsuccessful after 4 weeks, then proceed to surgical evaluation. And in terms of complications related to spontaneous abortion, one can be hemorrhage, which can occur during spontaneous abortion or during or after the surgical treatment. Remember that this could lead to maternal death. And risk factors for this include uterine atony after surgical treatment, cervical injury, uterine perforation, subinvolution of the placental implantation site. That's all for this review about spontaneous abortion.